Hi, everyone, and welcome to today's webinar. My name is Cindy, and I'm the Multiple Myeloma Education Manager at HealthTree. We're so excited for today's presentation and are grateful to NBMT Link for providing us with this opportunity to connect with you. Now, before we get started, our speakers have asked for you to take just a few moments to gather a pen and paper. That way, if there are any questions that come up during the presentation or something just inspires you, you'll have that opportunity to jot that down. There'll also be some exercises during the presentation that will require pen and paper. So take a few moments while we're introducing today's presentation to get that done. We want to start by introducing the organizations that are providing this webinar today. First, I have the great pleasure of introducing NBMT Link. The National Bone Marrow Transplant Link is a nonprofit organization dedicated to serving individuals before, during, and after a bone marrow or stem cell transplant. The mission of the National Bone Marrow Transplant Link is to help patients, caregivers, and families cope with the social and emotional challenges of bone marrow or stem cell transplants, from diagnosis through survivorship by providing vital information and personalized support services. The programs on the screen are free and wonderful sources of information and strength for patients and loved ones as they navigate bone marrow or stem cell transplants. For more information, visit NBMT Link or the other sources on the screen. Secondly, HealthTree, whom I work for, is a global nonprofit that supports blood cancer patients and caregivers through lifetime personalized support and education, meaningful patient-to-patient connections, and a powerful patient data portal that we call HealthTree Cure Hub. At HealthTree, we're committed to providing the most accurate and up-to-date information about blood cancer. We provide patients and care partners with online blood cancer-related resources that help them make more meaningful, informed decisions about their care. We've developed programs and tools designed to help patients and care partners find people who understand what they're going through so they can support and learn from one another. All of the resources on the screen can be found at healthtree.org. If you have any questions about our programs and would like to reach out directly, I'll have my email address on the last slide of this presentation, and I always welcome all contact from those enjoying our webinars. Just a heads up, this meeting is being recorded. And then after the event, we will send a link to watch the recording and any resources we mentioned straight to your inbox. You can also find the recording later on our website and also on the NBMT Link website. As we go along, feel free to drop any general questions or comments in the chat. We'll keep an eye on them. Our presenters will answer all audience questions during the Q&A at the end. If you need help with any Zoom features, just let us know in the chat. We're happy to assist you there. To access the chat, click on the chat icon. If you're on a mobile device or a tablet, you may need to tap your screen and then the chat icon should show up. We're excited to hear from our speakers today who will guide us through delivering tough news to blood cancer patients. When NBMT Link approached us about partnering on this webinar, we jumped at the chance. Being a nurse myself, this is one of those things that I know I didn't learn in nursing school. Though I wasn't often the person delivering the news, I did have to be there and support patients after that news was delivered. So I know it's an important topic that everyone in healthcare, no matter what their role, is involved with in some degree or another. I'm so excited to introduce today's speaker and learn from their experience and expertise. So these are our two speakers for today. Dr. Andy Harris is a member of the MSK Kids Transplant and Cellular Therapies program at Memorial Sloan Kettering Cancer Center in New York City. He serves as the Director of Pediatric Transplant and Cellular Therapies Fellowship, Associate Director for the combined Memorial Sloan Kettering Weill Cornell Pediatric Hematology Oncology Fellowship, and is the Director of their Pediatric Multidisciplinary Graft versus Host Disease Clinic. Dr. Harris is an internationally recognized expert and performs clinical research in graft versus host disease. Dr. Harris brings a unique perspective to today's discussion as he is also a leukemia survivor who had an allogeneic bone marrow transplant in his late teens. Jennifer Gillette is the staff social worker at the National Bone Marrow Transplant Link and provides counseling at a private practice in Troy, Michigan. She is experienced in oncology, bone marrow transplantation, and assisting people in coping with illness. She received her Master of Social Work degree from Wayne State University. She has spent 20 years leading the psychosocial support programs for oncology over Providence Hospital and Providence Novi hospitals. She provided private counseling, led support groups, assisted with educating patients, developed patient programming, assisted with research projects, and led the Fellows Clinic, a place for people to receive cancer treatment who had no insurance and were socioeconomic crisis. At MVMT Link, Jennifer is available to assist with emotional support resources and assist with supportive programming. With that, I will go ahead and turn the time over to Dr. Andy Harris.
Thanks, Cindy. Let me share my screen and then get my talk up. All right. So hopefully that looks good to everybody. Thank you all for joining us. And for those of you that are watching this afterwards, hopefully this will give you some insights and be of use to you. So I was asked to give a 20-minute talk on tips to deliver tough news to blood cancer patients. And I always want to start off my talk with acknowledging that delivering tough news is something that none of us really is a big fan of having to do. This is a tough part of our job, but it's really an inherent part of our profession. This is part of the responsibilities that we accept when we take a patient under our care. So in acknowledging that, let's move on to the talk. So when I think about examples of tough news scenarios, some of the ones that come to everybody's forefront in their mind are whenever we have to make a new cancer diagnosis, when a patient is not responding well to therapy and we've got to change gears to a different treatment to try to get to that goal of cure. If we have a patient that's had a good response, is in remission, and then their disease relapses or recurs. And for those patients for whom we no longer feel that cure is an option, when we need to adjust the goals of care and talk about end of life. But on top of these, there's additional ones and tough topics that we have to talk about with families throughout the whole process. In my role, where I am a transplant physician, I think that having to acknowledge with the family that often the only chance for a cure for their patient, for their loved one, is going through a bone marrow transplant, which is a high-risk procedure. Additionally, when patients are going through therapy, at times they'll have complications that can be scary and life-threatening, including sometimes needing to go to the intensive care unit. And another example of tough news is when there's a mistake that's happened in the care of a patient and how to discuss that with the family. So when I look at all of these different ones, and there's many others that are out there, the two that are now in blue, the new cancer diagnosis discussion or the need for a stem cell transplant, yes, you're delivering tough news, but then you have to deliver a whole plan kind of as a package to them and help them understand what's going to be happening over this next several months to however long it may take for their cancer journey and for their treatment. And some of these other ones are things that just come up when things don't go well. So I kind of lump them this way, but there's also when we have a patient that's having a poor response to treatment or has a relapse of their cancer, we then also have to put together a plan for how we're going to manage this and how we're going to move forward. So for all of this, I think one of the most important things that we do in our job is we develop relationships with our patients and their families. And this starts really with the first time that we meet a family, and developing this connection is really essential to having this therapeutic relationship with the patient and with their loved ones. And what we need to learn and understand as the healthcare providers that need to be able to deliver this news and this information that oftentimes can be complex, sometimes overwhelming, so we have to understand the education level of our patients and their loved ones to be able to reach them and give them this news in a way that they're going to be able to receive it and understand it. And we learn this in part through our small talk that we have with them. And we also learn their preferred communication styles. So that way we can, again, reach them in as much of a place of comfort as possible when delivering this tough news. We also learn through these discussions how well they handle this hard news that we have to share with them and how much information they can grasp in a single setting. Sometimes we have to chunk information for families if it gets overwhelming or gets to be too much for them, and understanding what these limitations are for families can make it easier to deliver this information in a way that they're able to receive it. I think it's important to acknowledge that every single patient and every single patient's family is unique. And we as healthcare providers, we are unique as well. So whenever you put two unique people together, that dynamic that happens between them, or you have a unique group of people together, that dynamic that happens when you get that group in the same space is also unique. So every single one of these talks is going to be different and tailored to the needs of the patient and given, through the style of the person that's providing that talk. So how I give a talk to one family is not going to be the exact same talk that I give to another family. And how somebody else would give the same talk to a family is going to be different than how I do it. It's a matter of finding your communication style and how you share that information and learning what tools you have that work well in different situations, and then putting those to the best use that we can. So talking about communication, as we all know, communication is not just words going back and forth. And communication is really the primary means that we have for developing and establishing this therapeutic relationship with our patients and their caregivers. But communication involves a lot more than both talking and listening. And for me, communication is an opportunity for constant observation of assessment of a patient and their caregivers and how they're doing, how they're handling the information that we're talking about. When I first talk with the family, I'm assessing their vocabulary and then the words that they use to try to get a better understanding of their education level, how savvy they are coming into this talk, if they've had time to prepare and do some of their own reading and research. And this helps me gauge how this talk is going to go and what type of words and vocabulary I need to be using in order to meet them at the level that they're at to get them to the place that I need them to be. But just as much as we focus on the words in these conversations, there's a lot of nonverbal communication that happens in these talks. And I'm talking about things like body posture, tone of voice, things like that that we can pick up on. And these nonverbal cues can really express, just how stressed or uncomfortable a family is. And when these verbal cues are changing, these changes also have meaning. And it's always important to continue to assess throughout a communication with a family when these changes happen, because they may tell us when we need to take a pause, when we need to slow down, or when a family is ready to move on and continue to hear more news or have further discussions. And these are important things to be able to make sure that we've not got them to a point where they're full and they're shut off, where they're not able to receive additional information that they need to hear. And then we can take a pause and then come back to it when they're in a little bit of a different place where they're able to do that and ready to move on. It's also important to remember that our nonverbal cues are also very important, and families notice ours. So if you're sitting there very defensive, arms crossed, leaning far back or leaning towards the door like you really don't want to be there, they're going to pick up on that. And that's going to inherently put a divide between you and the patients and cause some disconnection when really we need to connect with these families to help navigate them through the tough news that we have to share with them in the time that we have with them. So I'm going to focus the next bit of my talk on delivering tough news, both at the beginning when we have to talk about a new diagnosis or a new treatment plan. I'm going to have a little bit in the middle about all the things that can happen in between this. And then I'm going to talk a little bit about when we have to shift the goals of care from cure to comfort or non-curative goals, and focus kind of on those bookends with a little bit of information in the middle. So when we're first delivering a new diagnosis to a family, there's really a need to provide both comfort and hope to the family in what is a very scary and life-changing experience for them, with the need to give them the information that they need to be able to process to be able to move forward with the treatment plan. So things that I feel that are very important to provide are both the high-risk nature of the diagnosis that we're providing to the family, how we're going to go about treating that diagnosis, what are some of the risks that we may be facing, and what are the outcomes that we could be seeing as a result of the treatment that we're proposing for this family. And this covers everything from risks for infections, needs for transfusions, potential for specific complications from drugs that we're giving to families, to potential for cure and moving on with life afterwards, and how we do that, to patients who are not responding to therapies that we had hoped, and where we have to refocus our goals on providing comfort and palliation for them and understanding what that looks like to them. Additionally, during these talks, we need to assess how well they're understanding and receiving the news that's being delivered. And again, we can go back to these nonverbal cues that we're constantly assessing from these families to know when they're open, when they're receiving, when they're actively listening, to when they're shutting off because their mind is worried or fixated on something scary that they just heard and they need time to process that. And one of the ways that I found really helps me assess how well a family is understanding what I'm sharing with them is asking them questions, like, so what does that mean to you? Or So tell me what you understand about what we've just talked about to make sure that I understand that they're processing this information. Sometimes families will shut down and not be able to hear and process things that we feel that they're listening because we're saying them, and we need to double check and verify that. So it's important to take the time necessary both to develop this relationship with this family during this first diagnosis talk, but also to provide this understanding to them. So when we provide this diagnosis and the plans, we've got to do it in a way that's clear and in a way that the family can understand. So I think one thing we have to make sure we don't shy away from is the feared C word. We need to make sure that when we give a diagnosis, we tell them they have leukemia or they have lymphoma or they have myeloma, they need to understand that this is a form of cancer. And sometimes we forget that not everybody has that understanding. So I think it's important to make sure that that word gets mentioned in the setting of this new diagnosis that we're sharing with the family. And again, we have to do this using language that they understand. Most people understand what cancer is. A lot of people understand what leukemia is, but if you tell them that this is acute myeloid, undifferentiated myeloid leukemia or an ambiguous lineage leukemia, you're adding in a lot of words that some people may not have the savvy to understand. So if you need them to understand that, you need to say those words and then help them understand what those words mean. And while we're doing all this, I think it still is important to be expressing empathy to the family, acknowledging the emotions that they're facing, acknowledging this is an unfortunate, unlucky, and sucky situation that we're in, and validate any fears that they may have or feelings that they're processing at the time when they share those with you. In order to do that, I think it's extremely important that we are honest and authentic in who we are. I think trying to use a cookbook approach to give these talks is really doing a disservice to a family. And that's, again, the uniqueness of who we are as healthcare providers and the uniqueness of them as a patient, as an individual. Being as authentic as we can in that space really helps with developing that connection and helping them get that information sufficiently to be able to keep moving forward with our treatment plan that we have. Part of being honest and authentic with families is not making promises that you can't deliver. Even our best response of cancers, the lowest risk cancers, people still die from those. So telling somebody, oh, we're going to beat this, you don't have anything to worry about, I think is doing a disservice, because if you have a 99% chance of being cured and you fall in that 1%, the 99% chance doesn't really mean a hill of beans. So I never tell a family that I promise them a cure when I can't do that, but I promise them that I'm going to do everything I can to work towards a favorable outcome. But I can certainly promise them that I will be with them every step of the way along their cancer journey. I think it's also important when a family asks tough questions not to avoid them or to tell them, oh, we'll talk about that later. I think it's important to acknowledge those because these are things at the forefront of their mind that they're sharing with you. So I think it's important to address them at the time that they volunteer them as well. Being a pediatrician, I think it's also important to talk about when we're dealing with children and teens. They have differing levels of development, maturation, education themselves. But when talking with families, you have to understand how open they are to including the child in these discussions and how much they want the children to know. And we have to honor that sometimes even when we disagree with what the family's wishes are on. If they're open to the family's open to the child being engaged in these discussions, we need to, engage that child and figure out just how involved that they're going to be and how much they want to be involved in these discussions. And if they want to be present in the room but not be part of the conversation, if they're present, they absolutely are listening. They're absolutely thinking about things. Sometimes they are misunderstanding things. So I think it's important to elicit their questions and their understanding as well. And I think when we give this new diagnosis, when we set the stage for this cancer journey, all the things that we talk about in this first couple of visits that we have and conversations we have with the family sets the stage for any future difficult discussions we may have to have with them. We talk about things that can potentially happen, and we know many of the things that often will happen for families. We can bring these up front, so that way when we have to deal with them when they arise, it's not a completely foreign concept that's come to them out of left field. They'll remember, oh, we did talk about this, although we didn't talk about it much, and now we can talk more about what this means for myself or for my loved one and how we're going to go about addressing it. So moving on to when things don't go as planned, and these are things like a poor response to therapy or a relapse or an unexpected transfer to the intensive care unit or a life-threatening infection or any of these other things that we can envision. When we have to sit down and talk with the family about these things, it's important that we are prepared. You need to know what's happened that's led to where we're at right now. And as I mentioned before, hopefully the possibility of this scenario had been at least even if just very superficially, it's been addressed or discussed with the family or mentioned to the family. I think it's important to be transparent about what it is that we're dealing with. Um, Sometimes if you have a good connection with the family, being transparent in your own emotions about this complication, I think can also be an important way of connecting with the family and sharing with them and validating their feelings about it as well. Just like with any other difficult news, it's important to confirm their comprehension, their understanding of what it is that we're talking about. But then we have to be prepared to discuss the next steps with them. Do we have to do additional testing to help confirm a suspicion? Um, what does this mean for our treatment plan? Do we have to change it? Do we still have the same goals as we did when we started this cancer treatment journey? And if we're changing it, how does this affect the timeline for treatment? And what's the expected course here? So this is almost like hitting a reset um, from the new diagnosis. When we've talked about our treatment plan, we have to talk about what's changed and how we're going to navigate through that together. And it's also important to take the time to answer the questions that they have because they're going to have a lot of them. Sometimes they will have questions that they'll forget. And so it's important to check back with families. I'll often prompt families to, if they have questions that have come up that they've forgotten, and they remember them after I've left, to write them down so we can talk about them together when we're sitting back down together and having additional conversations. So moving on now to when cure can no longer be the goal. So the patient for whom they've not responded well to our therapy and our curative options are no longer on the table. This can happen in different settings. This can happen in the outpatient side where we're in a clinic room, and this is often a little bit more of an intimate talk at that time. But sometimes this is a patient's had a life-threatening complication where our treatment options are now limited and we can't give this in the inpatient setting. And in that setting, it's more often that we're involving a care team. So we're going to have a family meeting or a multidisciplinary family meeting. I think it's important to pick a time that works for the family, that works for the people that need to be present, and to establish a private, intimate location where we can have this difficult conversation. We obviously need to make sure that everybody's able to attend that needs to be there. And this often from the care provider side involves the doctors, nursing, social work, palliative care. If this is in the intensive care unit, one of the intensivists. And if the family has demonstrated an interest in engaging their faith in these discussions, making sure that there's a chaplain that can be present for this as well. Knowing the family and knowing what's important to them can help guide who is part of this meeting with these families to make sure they're not overwhelmed with having so many other people in the room and it feels an us versus them or a dog pile, but having the people there that can provide the appropriate support and information that they need in order to get through this talk and feel supported despite the change that is going to have to happen in goals of care for the patient. I think if we're going to have one of these multidisciplinary meetings with the family, it's important for the team to meet first to make sure everybody is aware of what it is that we need to discuss with the family, that everybody's on the same page. If they're hearing mixed messages from different people on the team, that's going to add to confusion, perhaps lead to some mistrust. And that's certainly not what our goals are when we have one of these meetings with the family. We're trying to provide support. We're trying to provide some comfort in a very difficult time, but also provide important information that the family needs to understand or the patient needs to understand about their cancer and their cancer journey. Additionally, during this pre-meeting, it's important to determine who's going to be leading the talk. If their primary oncology doctor is present and available, they're often wanting to take the lead on this because they've had so many of these difficult conversations with them, even at the get-go with the initial conversation. Or if it's somebody that may not have as much of a relationship with them, perhaps this family's already been connected with the palliative care team and they've established a relationship with the family. It may be best to have them take the lead. And it's important to have these conversations with the team to understand who's going to be taking point, who's going to be the main lead that's going to be guiding the discussion with the family. So when we have to have a talk about readdressing our goals of care away from cure to palliation or comfort or life prolongation, whatever it is that this is going to be the next goal for our therapeutic plan for our patient, I think it's very important that we're clear in our message. And it's hard to balance being clear while still being compassionate. You've got to find what, tips and tricks for how to do that. I know all of us have trained with and worked with more senior members and gotten to see how they do this and either say, okay, that's something that I could never see myself saying and that's not going to work for me. And that's important knowledge to learn, as well as, oh, I really like the way that they said that. And I'm going to find out how to say that message in a similar way, but using my words And again, being authentic in how I'm delivering this message. I think it's very important to acknowledge the sad and difficult nature of the news that we're giving. But again, we have to confirm understanding. If we tell them that this cancer is no longer curable, and ultimately the patient is going to die either from their cancer or a complication resulting from their cancer, they need to be able to understand that. Sometimes talking around it, patients will miss that message. So it's important to make sure that it's said clearly and that they've received it. When we tell them that we are no longer able to pursue cure, I think it's very important also for the family to understand that we are still here to providing care for you and for your loved ones and your needs. Even though we are changing what the goals of that care is, we are still here with you every step of the way. When questions come up, I think we need to be honest with them in our answers, again, not giving false hope or making promises that we can't keep. And that also includes when we don't know the answer to the question, acknowledging that we don't know the answer to the question. I think one of the more difficult questions that often gets asked when we're talking about changing goals of care is how much time does my loved one or do I have? And I don't think any of us are ever able to give a clear answer on that. Sometimes we can tell them we've got hours to days, days to weeks, or weeks to months. And sometimes we just don't know altogether if it's something that's more indolent. And throughout all this process, we have to give time for patients and their families to process their emotions, to acknowledge their emotions, to feel their emotions, and start the grieving process that happens in hearing that something is now terminal for them. And so this is something that's very challenging, but something that is an important part of our job and our commitment to our patients and their caregivers. I think additionally, when we're having this talk and we've delivered this news, we then have to be prepared about what our next treatment options are and give options for that. Are we focusing just on palliation? Are we keeping them comfortable knowing that this is a process that we're not going to be able to change? If this is a patient that unexpectedly has been placed on life support and we don't feel that they're going to improve from their current condition, we need to be able to have conversations about withdrawal of that support and what that looks like. And what are the limitations that can be put in place around this? This includes talks about do not intubate or do not resuscitate orders and things like that. And also we can talk about life prolonging options, non-curative chemotherapy or palliative chemotherapy that may be less toxic, but may give some additional time for them to be able to have opportunities to do things that are important to them, whether it's see loved ones, take a special trip somewhere, things like this, spend time with their pet, whatever is important to them. And then really they get to define what's important at this point in time. And the other one to remember is that sometimes there are non-curative early phase trials. For some patients, it's important to explore these and knowing what those are and what those look like for families if they ask about them, or be prepared to tell them, I'm going to be looking into what those potential options are and what those would mean for you. And we can sit down and talk about those later is important. After having this discussion about our different treatment options, families often will need time to process these different options, discuss amongst themselves what they feel is best in the moment for themselves, and then finally make a decision. After we've had this discussion and addressed a lot of the things that we feel we need to discuss in this meeting, it's really important to follow the cues of the patient or the family to discuss what needs to be discussed next. What does dying look like? Do they want to die at home? Do they want to stay in the hospital? Is the option for residential hospice? And that's one of those things that's rarely available for my pediatric patients, unfortunately. And what those different things would look like and what's important to them. What are they most worried about or fearful for happening? And then what can we do to try to allay those fears, to support them through those fears or acknowledge those fears if those are things that we fear as well? Again, finding out what's important to the family is so key. When we can't focus on cure and accept toxicity, we need to focus on quality of life. Are there people that they need time to have come to the hospital or time to be able to come into town that they want to have the chance to say goodbye to? These are the kind of things that, if time allows, can be spread out over the spans of days while families are processing this and trying to figure out what this all means and what things they really want to try to take care of in this time of dying. And so there's no one right way to do this. And sometimes that timeline will change abruptly. You've got to be able to sit down and re-talk about, okay, we thought that we had months, but this has changed and now we more likely have days. And so we need to figure out what to do about that and what things we need to have in place in order to make sure that the goals that you have, the things that are important, you can be addressed, respected, and fulfilled. The last thing I want to mention as far as being healthcare providers, These conversations are hard for us to have. They do take an emotional toll on us. We take our hits in this field. You need to take time to reflect on how these conversations impact you, how you're feeling about things, and make sure that you take time for yourself and for self-care as well, because these things, they can be very challenging. So make sure that you're taking that time for a personal emotional inventory, and that you're taking care of yourself when something has hit you a little bit harder than you had expected, or has hit you hard even though you knew it was coming. It still hurts. So with that in summary on my side part of the talk, delivering tough news is a difficult part of our profession, but it's something that we absolutely have signed up to do when we take on these roles. Communication is really a two-way street and involves a lot more than just the words that are shared. Conversations need to be tailored to each patient and family and the situation in which you find yourself. And these are all, again, unique dynamics every single time. And when you have to deliver tough news, you need to commit to taking the time necessary for each patient and family to give the news in a way that they can receive it. We have to confirm understanding, and the patients have understood and received the news that we need them to understand and hear, and that they have that the time is being taken to answer questions that they have in the moment, and that we take the time and follow up to answer questions that come up after this discussion as well. Being authentic throughout all this is key to keeping that connection with the family and establishing that trusting therapeutic environment that's inherent in what we do. And we also need to be able to show empathy and understand that this is emotional, this is personal, and this is life-changing. And last, be mindful of the impact that these conversations have on yourself and take care of yourselves. So with that, I'd like to thank you for your attention. I'm going to pass the torch on to Jen, who's going to give you the second part of this talk and do an exercise. And afterwards, there's going to be opportunity for discussion.
Thank you so much, Andy. I appreciate great tips here trying to help everyone. First of all, I want to welcome everyone to this talk. We certainly appreciate you being here and taking the time to learn about this very important topic. Knowing how to talk to people when they're going through challenging times in their lives is certainly an art form, takes practice, but it is such an important thing in building trust. So the topic for my talk today, helping when the news is not what we had hoped for. And I have a quote here from a book that I love sharing with kids, teens, even adults. There's so many great life lessons in this award-winning book. It's called The Boy, the Mole, the Fox, and the Horse. But in this book, it talks about everyone is a bit scared, said the horse, but we are less scared together. And if you remember nothing else from my talk today, please know that if we can make a patient feel less alone when they're going through this, we can help with so much of the emotional pieces involved in this journey. But we're going to start with an exercise, and I think it's important because it gives us a chance to try to jump into one of our patients' experiences. So on that paper and pen you have in front of you, I want you to use one whole piece of paper, and I want you to space your answers. But the first thing I want you to write down is I want you to take a second to just write something you highly value about yourself. Maybe a purpose you feel you have on this earth, a gift you have, and just write it down quickly. It's Family Feud style, just the first thing that comes to your head. And then take a space and write down the next prompt, your dream job. It could be the same as your purpose, but I want you to just think about the dream job that you always wanted, or a place you just feel like you click. And then again, a space. And then I want you to write a word that might describe your sense of spirituality or something with faith. I know that means something different to everybody, so it might just be meditation. It might be Christianity or some other faith system, but just write a word that whatever spirituality is to you. And then another space, we're going to write our partner's name or a word to describe your dream soulmate. If you haven't met that person, just something that makes you feel like that person would be the one. And then we're going to do another space and write a number for the income you feel you need to make a year to be financially stable. And for everyone, that might be different, but I want you to just kind of, no one's going to see this. This is only for you. So, but I want you to just write a number you feel you need to make a year to survive. Then a space, and you're going to write a physical feature you like, are most okay about yourself with. Maybe someone has complimented you about your hair, or maybe there's something about you that you're like, I like I'm tall. I can reach things on the top shelf. Whatever it is, write that down. And then again, we're going to take a space. You're going to write down your children's names or someone in life that gives you a sense of purpose. It could even be a precious pet, but something that when you come home at the end of the day, they're excited to see you. And then one more, you're going to write down a life goal or how you hope to spend your retirement years. And if you need a second, I've got them all on the slide that you should be seeing. If there's any you missed, you can certainly fill it in, or if you miss one or two, I think you still will get the general idea of this presentation. But I'm going to start the exercise, and you can follow along with me. There is nothing descriptive. I'm not breaking HIPAA with this story, but I'm going to share a story with you that's kind of got some little pieces pulled together from patients I've known over the years. And I'm being vague and broad for a reason. But I'm just going to kind of walk you through someone's story. Judy is a 45-year-old wife and mother. She has scheduled some tests as her doctors are looking into her fatigue. She put little thought into it as she viewed it as something just to check off her busy working mom to-do list. But to her surprise, she got the call and went through prompt whirlwinds of tests and procedures. She felt a multitude of emotions, but found herself mainly sticking with two alternating feelings: numbness and fear. She knew her world was about to change. After gathering all the follow-up together, Judy's doctor shared that she had cancer and that she would need to start treatment immediately. Judy felt she trusted her healthcare team and she had hoped that the treatment could work, but her entire world just got turned upside down. So many things were spinning through her head at once, she did not know where to begin. She first went into autopilot, survival mode, and started making treatment her focus. Judy had just begun coaching her daughter's basketball team this year. She called the principal at her kids' school and shared she would immediately need to step down. She received kindness and understanding, but it made her feel a punch in the gut when she did. Basketball proved to be something that helped her fit in as a kid, gave her life skills, and gave her so much joy. She viewed it as a way she could mentor, support her daughter and the other girls, and it was a way she could get back to her community. I want you to take a moment and first rip off the piece of your paper with something you value about yourself. That should be the top one, so just rip it away. Next, we're going to proceed. Judy's next call was to her boss. A year ago, Judy had received a promotion and became a manager at a community advocacy nonprofit. She had put her dues in for about 10 years at this company and was recognized as someone with experience, leadership, and expertise. She loved that she could help people with her work and mentor others to make a difference in her community. Her doctor told her that she would require a minimum of 6 months of treatment, but most likely more. She knew deep down inside her company would try to support her, but realistically could only wait so long for this position for her to return. Next, I want you to rip off the dream job from your paper. Fast forward a few months, Judy is in active treatment. She is fighting to beat this cancer, and mentally she tries to hold on to hope, but she knows the doctors have said it is serious and they cannot make promises. She has always been a woman of faith, but it has been difficult for her to pray lately. She is angry that she seems to be getting one complication after another. Doesn't this God that she has been faithful to throughout her life hear her? Doesn't he know her family needs her? Is she going to be okay? Whatever word you used for spirituality on your paper, rip it off. She has tried to find comfort with her husband, but he is struggling deeply with everything. They were having some tension before her diagnosis because she was pulled in so many directions, as was he. They were talking about getting into counseling, but they had put it on the back burner with everything that was going on in life. He was overwhelmed with doing all the parenting solo and trying to keep up the house. He always had difficulty asking for help and became lost in surviving in the moment. He continues to become more and more distant, which makes her wonder whether they will make it through this. There has also been financial strain, as she is on disability and only making 60% of her normal pay. He never says it, but she wonders if he is resentful of her with this burden. I want you to rip off your partner's name or the word you use to describe your future soulmate and rip off financial stability, the number you came up with that you feel you need to survive each year. Judy's youngest child is 5 years old. She has always been her cuddly little cutie. Her daughter and she have always had a special bond, but after months of treatment and being shuffled around by others, her daughter has been confused and less chatty with her. Her hair loss has also made her uncomfortable, and her father's mother has stepped in more, taking her for more days at a time. Since Judy's immune system has been suppressed, their interactions are very different. She misses their connections and wonders if her daughter is distancing, as she might subconsciously fear her mother won't make it. Now you're going to rip off your paper the physical feature that you like and your children's names. Fast forward again, more time has gone by. Judy is exhausted from her treatment. She has lost all sense of normalcy in her world and she feels alone. Although her family and friends try to support her, after months of care, they can only do so much as they have lives and people to look after too. Judy's doctor has a meeting with her and her husband to share that her treatment has failed. He shares that there is something else that could be promising, but he does not want to give her false hope. Judy feels breathless. The thought of possibly not being here becomes painfully real. In that moment, the thoughts of things she could miss, like weddings of her children, graduations, being a grandma, all the things that make her feel the panic of what could be. Rip off into shreds the life dream or retirement goals. You might have experienced emotional tugs with this exercise, and obviously that's what this exercise was meant to do. It's an empathy exercise, but take a moment to think about the multiple losses happening every step of the journey for your patients. Even sharing a basic bad lab result can be given on a day where they feel like their world is falling apart. So again, a key takeaway from this talk is be present, supportive, truthful, and kind. As fast-paced as we know healthcare is, we all know what it's like from that angle to have all the pressures that you have to accomplish every day. But these moments are sacred and we need to treat them as such. Walk with them on the journey and never let them feel like you are leaving them alone. Our patients experience complex levels of grief daily, and we cannot always change the weather in their world, but our presence should be like a cold drink on a hot day. We need to show authentic kindness and compassion. So as we are looking at ways to do this, I know a lot of this Dr. Harris has covered, but the importance of really being in touch with that body language. 70% of what we're telling them is with our body language. So even if you pick kind words, they will pick up on standing by the door, looking at your watch, fast speech, all those things that say, I want to get out of here. We need to slow down. Try to lean in, nod as they speak, show some of those gestures that you're trying to listen and understand. Clarify what they understand, like what Dr. Harris was saying. What I hear you saying is you want a couple days to think about it. We want to make sure we're understanding them as much as they're understanding us. Another thing I want to add here that I didn't actually put on this note, but something I've ran across a lot in my own practice in the years too, is make sure they understand the language, not only from an education standpoint, but also if you have a client who has English as a second language. For example, let's say you have a deaf client and they read lips really well. If Dr. Harris is presenting their news to them, he has a mustache. They're going to miss 50% minimum of what he says with a mustache. So having an interpreter present if someone is getting really big news could be important. I'll also give the example of there was a time where I had a client and everyone thought he spoke the language well. And so a lot of times we just had big conversations even without an interpreter. But he learned how to teach himself English from watching TV. And he kept repeatedly coming into the doctor and telling him, I'm having constipation. I'm having constipation. The doctor kept writing for stronger and stronger ways to have a laxative effect. Turns out he learned the word constipation from a commercial. And it was actually the opposite of what was happening. He was having horrible diarrhea. And we kept giving him stronger and stronger laxatives. Those things can happen when we have communication barriers. And so it is so important to make sure we are using all the tools we have to communicate appropriately. I also am going to encourage people to try to remove barriers while communicating. I know in the hospital, we do not always get the luxury of setting ambiance, but if you have a room that feels more like a living room, or if you cannot have tables in front of you, anything you can do to make it feel less sterile can make someone feel more comfortable. Again, don't talk too fast and carefully observe a patient's facial expressions and hand gestures, such as fidgeting. If you notice those kinds of things, you can even stop and just validate, like, I know this is a lot, and kind of pace yourself, because they also might not be understanding. Sometimes the minute people hear the word cancer, they check out. The brain turns off. And if you're talking, it's just going to be like, wah, 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 wah. So if you don't give them a second to kind of reconnect, that can be a problem. As well as anytime we are having conversations that are difficult, we always ask family members or support members to be there, because again, the minute your patient hears cancer, they might be gone. And so when they're in the car afterwards and talking to that loved one, they can say, did they just say what I thought they said? And as well as giving them permission and validating that I know this was a lot to hear today. And if you come to your appointment on Monday and you don't remember and have questions, we understand. We're here for that. And just validating that. Okay, so an important thing, the doctor is usually going to be the one who gives the medical news, the bad news. But we are a team. I look for the expertise of everybody on the team when we're working together. The doctor can explain the medical piece, and I will never pretend to be a doctor with a client or with a patient, but sometimes I will serve as interpreter. If I've worked with a doctor a long time and maybe they might not be as good as some other doctors in bringing the language to layman's terms, I will try to be an interpreter there. Social workers can also offer support and resources for practical needs and wishes. That is an important part of a social worker role. Chaplains can assess the spiritual needs and provide comfort in a way that's meaningful for them. And keep in mind, the chaplains on the team, some people might not want to talk to social work or chaplains, but we still can gently just offer ourselves now and then. And we meet the patient where they're at. I've had several people say, I don't need counseling, I don't need support, but then they come to our art studio and I'm in there for 2 hours and we're chatting, and little did they know they just did therapy. And here we are. Most people in healthcare have probably seen this distress screening tool, But check-ins could mimic this tool, or even periodically just being given where a family or a patient can fill it out. And it lets us know things that might be important. Like, I typically, when I'm checking on someone, might not be asking, are you having issues with childcare? Are you having issues paying your bills? What's happening? But those things might be a stress to my patient. And so if I am not aware of those things, it's hard for me to give them those tools. There's been times we've even helped patients figure out where their dog's going to be while they're in the hospital. And those things are very important. So as we walk beside them, it's important to know what is happening in their world as they're going through this, as well as the emotional piece, like looking at depression or sadness or anxiety. Like, could I teach a patient how to use some tapping skills? There's a great app called Tapping Solutions that I've shared with patients that it's research based. It can help with anxiety. And, if I know they're dealing with it, I can share some things. They have to decide what their secret sauce is, but we can be the ones that introduce, as well as letting them know they're not alone. Sometimes there's not a resource, sometimes there's not a tool. And I also want to let you know, sometimes there's not words. But even showing up in someone's room and saying, I want to check on you. I know you're going through a lot. Is there something I can help you with? And even giving them ideas on things that you offer. Because I also want to point out, sometimes we don't know what we don't know. They might not realize, some people might, like with social workers, think, oh, social workers take people's kids out of their home. They might not realize in full capacity what we're capable of doing. So sometimes you have to even kind of say, let me tell you some of the things we can help with, and see if they're interested. So asking questions on their needs, but also giving examples like I just said. And then sometimes that might be, can we recommend a counselor? Can we recommend a support group? Like if it's an advanced cancer, even if they're in a support group now, being in a group that other people understand what advanced cancer is like, that could be helpful. Or talking to a peer mentor. Many people, including MBMT Link, have peer mentor programs. And so we could try to connect them with other people that have gone through things. Support also involves asking individuals how they want to be cared for, and offering support to not only them, but their families and caregivers. We have things like I have here, like the 5 wishes, asking how do they want care decisions made, the kind of medical treatment they want or don't, how comfortable do they want to be. All those kinds of questions, if it is something that we feel is terminal, those questions, if they are still able to articulate, are important for us to ask and have those conversations. And as well as, what can we do to support their loved ones going through this? Sometimes it's also going to be social work helping them find places. Like some people want to be at home. Some people don't want to be at home because they're afraid of what that will do to family if they die in the home. And so really understanding those plans is important. We also, as I stated earlier, we have to acknowledge the grief. Anytime you get a bad result on anything, there is grief. Everybody's coping is going to be unique, and helping them think about the different ways they can cope. Some of it might be looking at what things in the past have helped. Like if they've gone through something with grief before, what things got them through that? Also helping them have ways to let those feelings out. Like maybe I show up as a social worker with a journal for them one day and say, some people really find being able to write about some things gets it off their chest and helps them kind of process it. Would you like to try it? Encouraging self-care, and that is for the caregivers as well. We look at caregivers as secondary survivors, so you need to be treating the whole family as you're going through this. Encourage connection with other loving family and friends, and remind them it's okay to take a break from grieving. Part of coping with loss is being able to go back and forth between grieving and participating in everyday life. It's okay to laugh and feel happy moments even when you're grieving. I remember there was one time I had a patient come in, or I should say her husband came in, and they brought their daughter. and they just didn't have it in them to tell them that her mom's cancer was terminal. And this poor kid was only like 8 years old. And it was such a hard session to have. And we all cried. It was rough. I know I was a wreck after it. And later that night, I called the dad just to see how was everyone doing, or is everyone doing okay? And the little girl was on the trampoline and had her cousins over, and they were playing. And everyone was kind of just taking a break. And to remind them that that's okay. You know, you don't have to live and breathe this all night. You don't have to live and breathe this every minute of every day. You're still a human being, regardless of what you're going through. So when you need to grieve, grieve, but when you need a break, it's okay to take a break. Offer support groups if appropriate, and if that is something that they're interested in. So another job we have as practitioners is helping them for their hope to transition. What you hope for changes, and we need to help them look for, even if they are terminal, they can hope for things such as comfort, peace, acceptance, meaningful moments with loved ones, and joy. I'm going to kind of skip through these slides. You can go through and look further for some of the ways for that, but also I have on here emotional needs, and again, like holding hands, being present in the room, spiritual needs, the needs to feel love and be loved, and some of the physical things we can do if someone's on an advanced journey. But I also want to point out, I put a couple resources in here. Many places you can get support online, even if they can't go in person, such as Cancer Care, Cancer Connect, Cancer Support Community, LLS. There's organizations you can turn to if someone is terminal to help them preserve images, stories, and memories for loved ones. And so you've got resources there, legal resources. We might need to help them as they're trying to figure out all those end of life issues, and Triage Cancer is a great resource for that. And then that will be the end of my presentation for now. Thank you so much for having me.
Thank you so much. I don't know about Dr. Harris, but I was not prepared to cry at work today, but it has definitely happened as we walked through that empathy exercise. So thank you for bringing that to us and, helping us think through all of the different things and that the patients do lose as they go through their treatment and through diagnosis. So, that's very, very good. So in that same vein, the first question that came up for me is, being honest and authentic. It often looks like putting myself in somebody else's shoes. And I know it was discussed, we need to make sure as healthcare workers that we're looking out for our own mental health. We're looking out for how we're processing all of this loss as well, because you do become so close to the different people that you work with. So I'm just wondering what resources either of you have discovered that would be helpful for the healthcare providers to process their own grief.
I'll let Dr. Harris go first.
Sure. So I think having colleagues that you work with that you trust and you develop relationships that understand what it means to go through that with the family are really helpful resources for me. Having my wife and kids at home that I can just hug the hell out of after a really tough day can go a long way. And another thing that's very therapeutic for me is just getting out in nature, going for a hike, finding that beauty that's out there in the world after having to have some terrible discussions and hard discussions with families. Those are things that really help me a lot. And again, you have to have that level of awareness of where you're at to know when you need to take advantage of these things. And so that personal inventory that you take can really go a long way to helping you make sure that you're taking care of yourself. Just like with a child that's got a bad injury, you hold it together for the family as much as you can for as long as you can, and then you process your emotions and everything else that come from that afterwards when the time is right and you have the opportunity.
Thank you so much. Jen, do you have something to add?
I echo what Dr. Harris says. I think that if other people on the team, like, you know, have built those relationships and they see together like just, wow, this patient is so special and my heart is just crushed. You know, like you can support each other. But I think having been in oncology as long as I have too, one of the ways I deal with the emotion, not only do I spoil the tar out of my kids sometimes and my husband when I get home, but I think it's trying to live life to the fullest too, that no day is promised for anybody. All of these people thought their lives were going to be very different. And so I it might sound kind of cliche, but I really try to live each day to the fullest and try to appreciate it. And I kind of feel like I honor my patients when I do that too.
I love it. That reminds me of a movie called About Time, where a guy is able to time travel, and he gets to experience life twice every day. He gets to, go through, excuse me, just the emotions of the day, and then lives it again, but with, fresh eyes, those vacation glasses, different things like that. So I think that's really important too, when you're in that mindset, be able to really appreciate what you have. So thank you both so much.
Mhm.
Um, we could talk for hours. I have enjoyed this conversation so much and honestly would love to continue, but also want to be respectful of your time. So I think we'll go ahead and close down today's discussion, and hopefully we'll get the opportunity to do this again in the future. So I'm going to just go ahead and share my screen one more time. So, and of course, want to thank both Dr. Harris and Jen for your time today and for sharing all of your thoughts and expertise and resources. It has been amazing just having this opportunity. So thank you so much.
Thanks for
Yeah.
inviting me to come in and share my thoughts on this topic. It's a challenging one, and it's one that's very personal for everybody.
And it was my
Awesome.
pleasure too. Thank you. It's been an honor.
Thank you so much.